I've had during my entire career, I've been interested in healthcare disparities. It's possible that I sparked that interest when I was 5 years old and had my tonsils taken out with a local anesthetic in a home office by an unlicensed physician. He'd lost his license because of alcoholism, and that was the only health care my parents could afford. So throughout my career of watching healthcare disparities maintain, we've done a very poor job in this area. In fact, today, an African-American baby is 2.5 times more likely to die during the first year of life than our white children. And in fact, their African-American moms are 3 to 4 times more likely to die in childbirth, irregardless of income. So what have we tried to do about that? There was a big movement some years ago to teach cultural competence. Basically, we were teaching stereotypes about minorities. And I recently had to attend one of these trainings where I was taught about a very rare instance when some Asian groups do something called coining. They think that warming coins and rubbing it on their children might help their health. That really is very unlikely to solve the problem of healthcare disparities. The next thing that we tried is we talk about implicit bias. So we talk about the fact that we judge people differently, we don't even realize it, and we should try not to do that. We should become colorblind in our healthcare system. I think that doesn't work well either. And maybe some of the answers of what we should think about came to me during an early experience I had. I was lucky to get in a very prestigious graduate program. And the first day of the program, we were all asked, we came into a room and we were asked to say what our parents did and what undergraduate school we had gone to. And all of my colleagues were very upper middle income folks. In fact, the woman said, I was the last one to speak. The woman sitting next to me, both of her parents were physicians, and she had gone to Brown University. And I got to say that my father repaired farm equipment, my mother was a grocery clerk, and I had gone to Idaho State University. Do you think it would have been helpful to me for somebody to talk about what my culture was? I don't think so. Or would it been helpful to me for people to be blind to my differences? Not at all. I can tell you I was well aware, painfully aware, that I was different from everyone else in my class. I needed 2 things, 2 really important things. One is I needed someone to reach out to me and help me with some of the deficiencies that I clearly had. I didn't write well. No one had taught me to write in the bad schools I went to. So I needed a tutor to help me write. And I also needed someone to understand the strengths I brought to this. I could see things differently than my advantaged colleagues. So that was very important to me, to be able to do that. So what would it look like if our healthcare system actually did those 2 things? So I had a patient, I did a randomized trial of treatment of depression in low-income minority women in the Washington, D.C. area. And when I'm first piloting a grant, I like to do every job. So I was actually out screening in family planning clinics for low-income women. And I met this woman, an African-American woman, who was 23 years old and had 7 children, 2 sets of twins, and she was terribly depressed. I was so worried about her. We screened her, and I talked to her. We were doing a pilot group, and I said, please, come to our treatment. I think we can help you. I want you to come. And she agreed to come. So the morning of our first group, I called her and said, I'm really hoping you'll be there. We really want to help you. She assured me she would be. Group started, and she wasn't there. So after the group, I actually knew where she lived. It was close. It was on my way back to my office. And I called her and said, I'm so worried about you. May I just come by and see you? So I went to her apartment. I opened the door to just a sea of little heads. She had 7 children, and her sister had left her 3 children with her. So there were all these little children, and I sat down with her and said, I'm so worried about you. I wanted you to come to care. What happened? She said it was raining outside. I don't have an umbrella. I got soaked. I came back. So we talked. She was actually quite motivated for treatment, but she needed outreach, which I did, and she also needed help with babysitting and transportation, not expensive things to help her with. She came to CARE and fairly quickly was able to disclose to us that her problem was she had a very abusive husband, and she firmly believed that she had committed to God that she would stay with him the rest of her life. And in fact, her oldest son was beginning to model after him, and it was just terrifying for her. So our group asked her over time, really, the God that you believe in, would he want you to stay in this horrible situation? She decided no with the support from our treatment. And she left him. She had all the strengths we have to understand in her culture. Her family had stepped away from her because of her relationship. When she left, her grandmother stepped up, helped her get an apartment. Her mom helped pick up kids after school, and she got a wonderful job in childcare where she could bring her younger children. So that's what it looks like when we reach out. Another example happened very recently to me. I was treating a young adolescent, a male to female trans young woman who felt terrible about herself, largely due to the way we reflect back these decisions for young people. And I felt I needed to hospitalize her. The procedure that I should have followed would be to call security and have them walk her to the ER. I can promise you I would never see her again had that happened. She is so traumatized by the way she's been treated in society. If I had shipped her off, it wouldn't have happened. I got colleagues to help me. We walked her to the ER. I advocated for her. I went to the desk and said, listen, we're going to have someone come in with a male name on the record. You're going to say she and give a female name, and really advocated for her and stayed with her, talked to the psych, got her tucked in, and I'm now seeing her as an outpatient, and she's doing quite well. She would have never come back to see me had I not gone the extra mile, and also really recognized her strength. This is someone at 13 years old is standing up to be who she is, and I needed to recognize that. So what does all this have to do with depression? What do we know about depression? Do you know that depression rates are lower among ethnic minorities in the US? Lower than among their more advantaged white people, largely because of culture. We think there's strengths in culture. But we also know when ethnic minorities get depressed, they're much less likely to get treatment than are their white colleagues. And when they do get treatment, they're less likely to get evidence-based care or high-quality care that will really make a difference. We do know that evidence-based care, those things we find in science, work well for our ethnic minority populations. We showed that in that trial I did in Washington, D.C. The poor women did as well as most people do in depression care. We also know from some studies that we've done here in both adults and adolescents that when we go into a medical system and actually improve care, ethnic minorities improve more than do the white population. So what do? We need to do those two things. We need to provide outreach, we need to provide help for those populations, and we need to really understand their strengths in order to make depression care equitable across all populations. And what happens when we do that? That young woman with 7 children, I've stayed in touch with her over the last 25 years. She remarried. She had a lovely career and now is a very happy grandmother with no return for depression. What about the patient? And my outpatient is doing extremely well in care and starting back to school and really building a life worth living. What about me? I stayed in and I answered questions throughout my career that no one else was answering. How can you bring care to low-income minority populations? So with a little extra care, outreach, we can repair those discriminations that people experience every day and actually make our system equitable for all with depression. Thank you.